Hello, dear colleagues. Can I start? Everybody here? Yeah? Everybody with the food? That's very good. So I think I can start.
Yeah. Shall I start and introduce you? You will start.
Ja. Oder willst du mich hier vorstellen? Kurz. Ja. Ich entschuldige mich selber. Ja. May I introduce myself? My name is Klaus Peters. I'm a gynecologist from Hamburg in Germany, and I'll talk about the topic hormone fear. But why? By the presentations that I heard before, I think the audience is well informed, and you're all experts, and you don't have the fear of hormones. So I have to convince you to convince the patients to lose the fear of hormones. I think that's the issue today. I don't have to convince you. So my biography, I graduated from school in California in '63, so you know I'm very old. I studied at the university in Hamburg, Germany. I started out my career doing research on hormonal cells, and then I became a specialist for gynecology and obstetrics. And since 1980, that's quite a while, you know, I'm in private practice, and pretty soon my daughter's going to take over, and I'll be her employee if she let me work a little bit more. And since '84, I started doing clinical research on hormonal contraceptives. Additional, I had my own institute do this parallel to my office, and I did many clinical trials and also on the pills that are on the market now. And besides this, I'm teaching also at the university, and I quit this when Corona started because then we did it all online, and so I thought, well, record my presentations and play them off, so I quit doing that. My disclosures, you know, I did studies for all these companies that you see. I don't want to list them. I want to win time. I don't want to lose more time, but of course, I got paid for doing all the clinical studies. Now, some statistics. We all believe in statistics, and we know every day worldwide 100 million couples have sex. I think that's just something to imagine. And this is 3,125,000 about now during my presentation. Yeah. And 50% of these acts are unprotected. So you see, there's a lot of for us to do for contraception. It's a wide field and many things to do, and we just talked about the youngest mother I had, where when I delivered the baby, when I delivered it, she was 12 years old. We shouldn't forget that 50% of the 14 years old girls had their first sex already. So it has quite an impact. The topic we have today, just the adolescent girl, should be in our focus. And every day, 1 million children are born and 150,000 are interrupted. That's an incredible number. And worldwide, about half of the pregnancies are unwanted. And the really sad and bad part about it is 200,000 deaths annual per 50 million abortions. I think that's a horrible number. So now, what are the questions for contraceptive counseling? We see the impact it has. First of all, and I think that's all what we go for, at least I do, and I'm pretty sure you do the very same thing, is how reliable does contraception have to be, and how problematic would a pregnancy be at the moment? So for the choice of the safety, I would always ask the girl, what would be if you get pregnant? Would you have the pregnancy interrupted, or would you accept the baby? I think this is also important to know for the choice, because it says, no, I would never get the baby. It has to be a very safe thing, and if not, we say, okay, if I would accept the baby, I think this is a different option. And now our main topic, hormone fear. How does the patient feel about the use of hormones, and what are the reasons for refusal? What concerns and wishes does the patient have? And this is the point where I sit down and let the girl talk. So I try to make her talk and say, well, what are your jobs? And then I can go into it and pick up the point that she has most of it. And we know most of it is some friends tell her some stupid things, and Dr. Google knows everything better anyway. And then, of course, the safety. That's the main issue. In addition to contraceptive efficacy, we have to have some aspects for safety. We don't want to have any risk with the pill. I say the pill. You know, the girls, they don't say, I want contraception. They don't know even the word. They say, I want the pill. And the family planning. When is the pregnant plan? When it's desired? If she wants to get pregnant within a year, and some young girls, they want to get pregnant pretty soon, I wouldn't go for a long-lasting method. I would do something that she can quit any time. So the pill is the option, not an intrauterine device or an implant, for example. And then, of course, I always look at them and evaluate the compliance. I would kind of try to guess how compliant, how can she take the pill? Will she be able to take a pill every day? And how's it plannable in the daily routine? You know, some girls, they're on a party, they don't come home at night, 14 years old, the average they get a pregnancy. They don't have the pill with them, so they skip the pill. So we should take pills that guarantee a certain safety, even if the pill is skipped one day. So how does the prescriber decide? And I'm very sure this is something that goes on in your mind, just like in mine. And I just made it in a graphic so you can see. First of all, we go for safety. We want a safe contraception. Everybody, I think, of you says, okay, it must be safe. Like condoms are not very safe, we know that. The second thing is the risk factors, health problems, contraindications. You know, many things that would be not very good for a combined pill, so we have to choose a progesterone-only pill maybe if there are contraindications like thrombose in the family or high risk and all this. And we can also improve health problems like dysmenorrhea, migraine. We can improve by progesterone-only pill, for example, or premenstrual syndromes. All this we can improve with the pill. So we also have a very good benefit sometimes when we have the pill. So often very many girls come because they go for the additional benefits. Mainly it's the girls with a lot of acne. We know when they have the acne in this age, this is also when they come where they have the worst acne, and we know acne makes scars, and they have to suffer from that for a whole life. So I think it's our job to prevent a bad skin for the rest of their life, and we can do it very easily. We have the tool in our hand. And also, it's very important, as I mentioned before, the method must be very useful. The compliance is important. She must be able to take the pill every day. Besides this, we also have to think about how long is it planned, when does she want to have her first baby, and also the patient's attitude towards bleeding. In the preceding lecture here, it was mentioned before that the bleeding very often is a problem, and for many religious group, they think it's necessary to get clean or so, and it's very difficult to say something about this. But of course, you know, in nature, bleeding isn't the normal thing. In the Stone Age, I think women never had a bleeding because they were pregnant, they were nursed, breastfeeding, or they got pregnant again. So nature didn't plan the bleeding, but in our civilization, of course, since we prevent pregnancies, bleeding seems to be normal, and the girls think it's normal. And I always say, well, what happened before you had your first period? You didn't have bleeding, so this was normal too. And after menopause, you don't bleed either. So it helps them to go over that bridge. And the fear of hormones, you know, that's a big problem because sometimes the girls are very afraid to take hormones. They think it's something unnatural. But why are they afraid? Well, they're afraid with related physical side effects. They think they have altered mental health, you know. They think they're in bad mood, and they heard some girls get depressions from it, and Dr. Google hits on that quite a bit. And of course, they think it has a negative impact on sexuality. At that point, I say, okay, if you think so, you can try the pill. You can always quit if you think so. So with that argument, I can go over this without long discussions. And then they're also afraid of future fertility. I heard, you know, from some friends that heard about it, that if you take the pill, it's not so easy to get pregnant. You can easily convince them that it's not the case. And also the invocation of nature. And I think now we have new tools. We have pills on the market with natural hormones, and it opens that door and say, well, we have hormones in the pill that are identical to the hormones you produce, so that's not an issue. And also the concerns about menstruation. I mentioned this before, and tell them menstruation is not necessarily the natural thing, and it must not be. And just general fears and anxiety. They really can't say what they're afraid of, but they're just a little bit afraid of it. And so the delimitation of side effects of hormonal contraceptives, that's an issue we have to deal with for the fear of hormones when we have the girls for consulting. This is a slide you shouldn't try to get into. It just shows that the more educated the girls are and the more intelligent, the easier it is to convince them that the pill isn't necessarily something bad. But the lower the educational status, the more fear there is. That's what this slide would show, so I just go over it. And there was a TANCO study. The TANCO study was a short form for thinking about needs in contraception, which simply meant there was a study made to see what women want, what they think, and what the prescriber thinks. The women, they think they need more information when they come for the consultation for contraception. And the prescribers have a different attitude. They think they did almost enough, and you see there's a gap, there's a difference. So this picture will show us that we have to consider to do a little bit more about information for them. We always underestimate the need of information the girls have. That's what I want to say with this picture. What are the methods used? They differ quite a bit. And also the TANCO study, thinking about needs in contraception shows what methods are used. In the European Union, about 34% use combined contraceptives, so that's number one. And a lot of them, almost as many, use condoms. And condoms really are not the very safe thing. That has a very bad Pearl index. And it's interesting, in different countries, depending on how the counseling is done, this is quite different. And now let me show you how the contraceptive use is for adolescents in Germany. I can speak for Germany now. And you see 86% of them get combined contraceptives because it has everything. Combined contraceptives have the period, so we don't have to talk about that they bleed or not. They do bleed because it's combined, and except they take a long cycle. And I think this is due to counseling. And all the other methods in Germany have a very small part of the market. So by this we can see that the adolescent women's decision about what combined hormonal contraceptives they take is mainly influenced by counseling that provides balanced information about all contraceptives. And now just some other aspects we also have to communicate. And when we talk about it and when they come for counseling, always says, well, do you have dysmenorrhea? And then they say, yeah, I didn't mention. I think dysmenorrhea, I always thought that was a natural thing. And we say, no, it's not a natural thing. Estimated, just how much they suffer, 50 to 90%, just give it on, can discuss it, of women in reproductive age are affected by dysmenorrhea. That's quite a bit. And 5 to 15% with dysmenorrhea experience symptoms that are so severe that they interfere with their daily activities. And these severe interferences can also result in limitation of activity so much that they even, young girls, cannot go to school, which also has other side effects. They miss school, and that has an effect on their further life because they miss their education. So what I do is I have a little picture here. I don't know if you can see it all, but I go through it clockwise now. So when they come, they have the risk. I say, well, okay, I start with the risk first, and then I have the benefits. So the risks are the cardiovascular. They always say, I heard it can cause thrombose. Then I say, okay, if in the family, and I go for it, if there has been a thrombose, then a combined pill would be good for you, and I find another method. so I exclude this. Then they say, well, I heard it is always an effect on the weight, which is not true, but here I have a point where I say, okay, if you gain weight with the pill, you can quit and you are right there where you were, give it a try. They accept that. I have heard that it has an effect on the peak body bone mass. Well, this is something we can discuss at the point. I want to go into it, but we all know it can be discussed, but mainly it does not, especially for the very thin and skinny girls. It has, I think, more a positive effect. And then I heard it has a higher risk for carcinoma of the cervix. But this, I did the studies about this, and I found the effect on the risk for carcinoma of the cervix is so minimal that it really can be neglected. And then they heard, well, it can, for later on, cause cancer of the breast. Well, that's also so minimal, and well, that's very relative. I think the benefits will be much better. So what are the benefits? And then the next point I come with, well, do you suffer from mood changes or premenstrual syndromes when you have your period right before it? And when I say, well, this can be improved, they think, well, this is an option. Dysmenorrhea, and we all know contraceptives are a good way to help the girls with dysmenorrhea, as you mentioned before. And there's something, too, we never think about. You know, if we give a pill that prevents ovulations, we have no ectopic pregnancies. All the other methods, they allow ectopic pregnancies. With the pill, we do not have it. And also the reduction of ovarian cancer. Well, this is something the girls won't go for, but just for us to remind, say, well, there's a risk for ovarian cancer later on maybe, but the risk is reduced. And also the cancer endometrium. Well, this doesn't affect young girls so much, but can also be mentioned. And interesting, the risk for carcinoma of the colon is reduced quite a bit if they take a pill. And all over, mortality risks are reduced, not increased. And first of all, too, acne. Many, many young girls, as I mentioned before, have acne, and we can help them very well with it. So these are the points I talk about with the girls, and I realize that they get quite a different attitude. So just to remember you, I just showed you a picture about ovarian cancer. The findings suggest that oral contraceptives prevent more than 200,000 ovarian carcinomas, and so 100,000 cases of death from that. Just benefit of the pill, by the way. And the next decades, the number of prevented ovarian carcinomas will be increased by 30,000 every year. But this is, you know, the girls will never know if they would have been affected, but something we could put into the discussion, especially by the well-educated girls, and some young girls are very smart and they can understand that. So the conclusion of what I bring now is women are interested in receiving more information about all contraceptive methods. We should be aware that the wishes differ widely, and greater exploration of needs and expectations of contraceptives could lead to increased knowledge and more effective discussions with HCPs, and the greater likelihood of information about contraceptive choice. That's what Professor Bitzer said. I'm citing Bitzer. And the inclusion of individual needs could contribute to a higher level of satisfaction, acceptance, and adherence, and to a better choice or change to a more suitable method. You know, sometimes they have a method before we can join it. Another thing is providing women with adequate information on available contraceptives. The option helps to choose the methods that suits their needs more, as then women's decision about which contraceptives to use is greatly influenced by counseling. But we say that's has the main impact on what they choose. And adolescents should also receive complete and confidential contraceptive services. That's why they're there. And this is the bullet message I have today. The prescribers, the gynecologists, the genital practitioners, and the midwives. In some countries, the midwives prescribe the pills, are still the absolutely main option leaders for women to make the contraceptive choice. Just one pic that shows it, makes it clear. Here you can see, to make it short, then we were asked, who helped you to make the choice? And it's all the same. But in Sweden, it's different. Why? It's midwives that prescribe the pills, so they were the main occupation leader. I think this kind of demonstrates what I just told you right now. Thank you very much for your patience. I hope it wasn't too fast. I think we could talk about this topic for a couple of hours, but my time was limited, and I promise I have to turn over now to Dr. Kai Haldre, who will kind of put something on top of what I just said.
Thank you very much for this kind introduction. And thanks for all the organizers for organizing this session about the fear of hormones. It's my pleasure to be here. I'm Kai Haldre. I come from a small country, Estonia. It might be very different from other countries because we have only 1.3 million of inhabitants. And I work, here is a little bit about my own bio. I work as a gynecologist for more than 30 years. My primary duty is infertility patients, but at the same time I have been always involved in young people's sexual health. And now I'm a couple of years also responsible for transgender health in Estonia. I meet with with majority of trans youth and trans people. And I am a big believer in professional NGOs. I'm so happy that we have such kind of NGO dedicated to pediatric and adolescent gynecology. And I have been involved in my country for decades. And I'm also happy to be a member of the European Society of Contraception and Reproductive Health and have been involved there also. So this is to disclose. This presentation does not have any influence from WCPAG Richter, although our session is organized by this company. Just to start, I will give some details about my own country, and it very well echoes what has been said today earlier. Estonia has reliable data about teenage and all the pregnancies. We have registries. And I was happy to see there was in 2014 published a global overview about teenage pregnancies, and Estonia was included there, and this covered the time period of mid-90s until 2011, and among these 16 countries where data were available, Estonia witnessed the steepest annual percentage decline in teenage pregnancies. We have investigated the same trend later on, and here I don't know how, there are only two colors, but in fact there were more colors, but this higher one is Estonia, so we got rid of Soviet occupation, and then I have witnessed the period without contraception, without also hygiene products, so it was very nice to hear this presentation, so I have seen different times. And there has been immediately a very sharp decline in teenage abortions. The same is true to fertility rates. And what we were lucky to introduce in 2016 mandatory sexuality education in Estonia. In the beginning of 90s, modern contraception came in, and we have achieved the level of very low teenage pregnancy rates by now. We always compare ourselves to our bigger brother Finland, and we are there where it is one of the best data in the world. So showing this data, I can tell you I have been involved in all these developments during the last 3 decades, and I can tell you that I am a big believer in 3 big pillars in adolescent sexual health and rights, which is, of course, holistic or comprehensive sexuality education at schools, which is mandatory, then appropriate services for adolescents, and also that safe abortion and a huge range of contraceptives should be available. Today's topic is the fear of hormones, and I believe also that contraceptive counseling is the key. And concerning adolescents, we all know that those who have been involved, it is different from grown-ups, because adolescents have a lot of insecurity, and for a grown-up who is only involved with grown-ups, these questions might sometimes seem very primitive or but you have to take adolescents seriously and address everything and address their sexuality. This is number one. And of course, informing, educating, empowering is extremely important part of this counseling. And the method is chosen by the user. This is the golden rule, and we should never forget it. And there is also hidden agenda now and then behind what is talked openly, and this is the dimensions about sexuality. So it was mentioned already that this concern, but it is not only sexuality, it's also the whole body image, and sometimes it is even clever to address them proactively, because we counselors, we know what can be there in the heads of the young people, but sometimes they are even not able maybe to express what are their worries, and they don't know to which direction this effect of a particular method can go. So primarily, I think one of the aims of contraception is to get sexual satisfaction, and if this part is affected, then there is no compliance. People use it just a couple of months and leave it. We know that not very many of those where we prescribe are using it in 1 year, so there should be very easy access to come back or to communicate in the case there are some worries. And as been said already by Dr. Peters, that what are the most important, if we do a study, what are the most important attributes or qualities of a good contraception for a woman? It's number one is, of course, effectiveness, and then safety, and then side effects, because this determines the compliance. And these days, when we have this new climate movement, and especially popular among young generation and very big awareness, then this environmental impact has become also very, very important. There has been today a lot of talks about menstruation, but still I would like to bring you this piece of information just to use in counseling. Because is menstruation natural or not natural? We can even pose such kind of question. Menstruation in itself is that there is a spontaneous decidua-ization, there is luteal phase, and when the endometrium builds up, and then with this spontaneous decidua-ization, it releases an inflammatory cascade. And there are short and long-term adverse consequences. Short-term is dysmenorrhea, premenstrual syndrome, but even there have been hypotheses that this inflammatory constant booster of inflammatory agents or mediators can influence or be like pro-cancer, cancerogenic. And as we know, historically, there hardly were any menstruations in women's life, let's say ancient times. It could have been maybe in this very remote tribes, it has been estimated maybe 30 times per lifetime, and it started to change 2 centuries ago, and now in modern women it is 450 periods. So evolutionary, maybe this inflammatory booster every month is not good, and if we give this kind of information, then it might put the things in context. What is natural and what is not natural? Because pregnancy has a very favorable impact in a way, because there is high progesterone level, and progesterone, as we know, is anti-inflammatory. We know that many chronic diseases level off during pregnancy and then start again, like rheumatoid arthritis or others. So we kind of, with hormonal contraception, create a, let's say, artificial pregnancy kind of state. We can say it with some reservations. And concerning this fear of side effects, of course, one of the main fears, and maybe very much having a lot of publicity, is venous thromboembolism. We know that combined hormonal contraception has effect on liver, and on coagulation and anticoagulation system. And here we in turn know that what kind of estrogen we use in this combined hormonal contraception, and also what kind of progestin or progestogen. This very much matters. What is the effect on liver and how the coagulation and anticoagulation systems are affected. I like very much this slide from this recent publication to put everything in context. So what is the aim of development of new contraceptives? It is actually to get rid of this ethinyl estradiol, which has been historically for 60 years in combined hormonal contraceptives, because we know it has a very strong impact on liver and also on coagulation system. And on the other hand, we are trying to find the most progesterone-like progestin, which does not have unfavorable side effects. So here we have reached, let's say more than 10 years ago, instead of ethinyl estradiol, which is synthetic estrogen, estradiol-based pills came. Estradiol is this kind of hormone which our ovaries are producing. And now we have a new estetrol, which is also natural, which is synthesized in fetal liver, and we have a new pill, further development with estetrol, and with this, and now the progestin matters. So when we talk about venous thromboembolism, then we can see that the new progestin, drospirenone plus estetrol, has the most favorable profile concerning this worry. A little bit now about this new estetrol-containing combined oral contraceptive, which is like the last development in pills. In the molecule, estetrol is different from these two previous estrogens, which have been used in pills, especially to get rid of this ethinyl estradiol, as I have said already. And originally, estetrol is produced during pregnancy by the fetal liver. It has a long half-life, 28-32 hours at least. So it has also very high oral bioavailability, 70%. So it's also very good property. And what is also important, we know that these older pills have, with certain medications, there can be effect on it because of the effect on liver, but here there is no interaction with cytochrome P450 enzymes, so it's possible to use more safely other medication if needed. It's not converted back into estriol or estradiol, and it's not converted to any such kind of metabolites which can be dangerous in whatever respect. It doesn't bind to sex hormone binding globulin, which means that we don't need it too much. And it's excreted by urinary. And estetrol is called differently from other estrogens. It's a native estrogen with selective action in tissues, NEST. And this is because it has effect on estrogen receptors alpha and beta. And this means that in different tissues it has different effect. For example, it has much more favorable effect in blood vessels. It has favorable effect in inner genital organs. And on tissue level, what is different also, that in a cell, this is a cell, estrogens have effect on estrogen receptor on a nucleus level and also on the membrane, but estetrol has a unique profile because here it works like agonist and on the cell like antagonist. So it's a very promising concept to use this knowledge as well. Now, the new pill with estetrol and drospirenone is available since 2021 in many countries, and before coming available, there has been, of course, phase 3 developmental program, and I'm happy to see that there were also young people included. There has been a published experience among more than 3,000 women, and it included also more than 500 women in Europe, 18 to 20 years, and in US, Canada, 16 to 20 years. So it has been shown, according to this study, that the new pill is very effective. So effectiveness was number one, what women want, among young people and also among older users. And it's always interesting to see that whatever contraceptive study in Europe, it's more effective than in the United States. It's another discussion, but interesting one. And also, what about failure rates? So if there is a perfect usage, then pregnancy risk per cycle was extremely low. It was 0.09% in participants who reported using all active pills in a particular cycle, regardless of any new medication started or health issues. And the likelihood of pregnancy occurring in a cycle remains still under 1%, even among those who reported not using as many as 2 pills in a cycle. And these pregnancies happened during the first 3 cycles of usage. And cycles in which participants recorded 1 or more missed pills did not result in pregnancy unless the missed pill instructions were not followed. So counseling is important. Compliance was extremely high, and there was also a quality of life questionnaire, and in the beginning of the study and in the end of the study there was high satisfaction, so to say. Then about discontinuation, it's extremely important that when we agree with a patient upon a particular contraceptive method, that they will like it and start to use it. So as we know, the main obstacle, or what we always have to proactively address, is bleeding. So these are percentages among the younger users, 16 to 20 years, and altogether more than 500 of them. And there was 3% who stopped using because of different bleeding problems. And because of acne, mood swings, and weight, they attributed their weight gain to contraceptive. This was 0.6%, which in absolute numbers is actually 3. 0.6 makes 3 participants, so it's also very low. And now coming to this new area of environmental awareness. There has been also, I'm not so sure, I don't know exactly when did these studies start, but I'm absolutely, I don't think they started in 60s when the new pills were introduced. What is the impact on environment? But it has been stated or estimated that every year 700 kilograms of ethinyl estradiol is distributed to the environment. And it is very well known that it can affect, it goes to water, and it can have an effect to reproduction of other species than humans, what is not desired. So recent, let's say, research about products and medicals, there is a kind of OECD methodology how to study the effect on environment. And here the study subject was zebrafish, 21 days, and they gave a huge concentration of 1,000 times bigger than we normally use it, of estetrol, and they did not see that it would have been affected zebrafish reproduction or let's say indicators of it. And in comparison, environmentally relevant concentrations of ethinyl estradiol resulted in concentration-dependent impacts on fecundity and biomarkers of estrogenic activity. So this is a piece of information what you can also use when you talk about those young people who have fear of hormones because of the environmental concerns. I think it is very important to say that these days this moment is checked and also investigated. There is now, it just was finalized next study among minors. So the study group about esetrorpil, using esetrorpil with phase 3 open-label multi-center study included youngsters from 12 to 17 years and 2 months. And it was done in different European countries, and including Estonia. So those who are still thinking, where is Estonia? It is here, and this is Finland, this is Sweden, this is Latvia, and this is Lithuania, Poland, and Georgia. So these are the countries where this 100 participants were recruited. And we hope to see the results published in 1 year. So I hope we will be able to tell it to you and say how it has been among our target group. So thank you very much. And I don't have any conclusion slides, but to conclude, I really find it extremely important. As I said, I am a believer in NGOs, in professional NGOs, and also cooperation between professional NGOs. And since on international level, where I have been involved mostly is the European Society of Contraception and Reproductive Health, I can see many ESC friends here in the auditorium and also as organizers. So once again, I want to repeat what Dr. Gabriele Merki-Field already said, that we will have a congress in Bilbao in May next year. And I believe in this cooperation between these organizations also. So thank you once again. Thank you.